Hello, colleagues, do you hear me?
Hello.
Hello.
Yes.
Uh, Is it okay with the sound?
Yes.
Okay, I suggest you today I'll present you two lectures, as I said you yesterday or the day before, because we have no time and we missed some dates because of the holidays. So the first lecture will be rheumatism, the second one will be spondyloarthropathies between 4:30 and 6 p.m. But I suggest to wait a little more students to join, because as far as I see here on the screen, my computer, you're 12 for now. I suggest to wait a little bit, 5 minutes maybe, a few minutes more.
Yes, okay.
Okay. I suggest you to turn on your mic, to switch on your micros, because it is easy to contact instead of chat writing and sending a message. It is more difficult and more we shall lose time otherwise.
Okay, Professor.
The main function is sound. I suppose you can hear me well. If there is something wrong with the sound and hearing, I suggest you to tell me or to write to correct the sound technique, because sometimes it is a technique and sometimes there is a fault. Okay, then it's more, and we shall start with rheumatoid arthritis, which is the main nosological, the main disease, as it is often we say it is a key pathology, a key disease, because arthritis is the most important, and we start from rheumatoid arthritis and then go with other inflammatory autoimmune diseases, and then systemic connective tissue diseases, and so on. So now you gathered with 17, you 18 is good. How many students your course complies? How many students are in your course?
Around 50.
Around what?
50.
Around 50. Okay. I suggest to start, and the remaining of you who joining later will join later, because not losing a time. Do you
Okay.
agree? Okay. So rheumatoid arthritis is autoimmune chronic systemic. Do you see the slides and presentation?
Yes.
Okay. It's chronic systemic inflammatory diseases, which is characterized by progressive symmetrical inflammation of joints. Some words about epidemiology. It is the most common systemic inflammatory diseases. The prevalence is between 1 and different countries. Usually it is 1.5%. Occurrence age, but the most important peak age for starting disease is about 40 or 50 years of age. The ratio between females and males is 3:1. Females are suffering more often from these diseases than men. The etiology is unknown, between genetic predisposition and mental triggers. Some words about pathophysiology. It is autoimmune disease, of course, and the main starting point in pathology and pathophysiology is a lack of between self and non-self tissues. So the organism, the body as a whole, cannot differentiate between self and non-self tissues. And as a result of that, a destruction of synovial and connective tissues. The final result, histological, is formating of tissue called panos. It is inflamed proliferating synovium, which invades cartilage and bone surface and leads to joint destruction. It is very characteristic of rheumatoid arthritis. You see here at the right-hand side, there is a normal joint, and a little below there is a inflammation of synovium, hypertrophy of synovium, and panos, which erodes the cartilage and bones. This is a little bit picture and scheme about the different autoimmune cells, B cells and T cells, and antigen-presenting cell, which is usually macrophages, which secrete many different cytokines important for pathophysiology and pathology in rheumatoid arthritis. And here at the right, you see the drug targets. Different drugs attack and influence different cytokine secreted by these cells, and as a result of that, we have treating results for this disease, which is very complicated and very difficult. So, what role of B lymphocytes and T lymphocytes, and which they secrete, especially B lymphocytes, pro-inflammatory cytokines. B lymphocytes usually originate in bone marrow. They produce rheumatoid factor and anticyclic citrullinated peptide, it is called anti-CCP, attract neutrophils to sites of injury, and act as antigen-presenting cells to stimulate T cells in the immune process. T lymphocytes, they are mononuclear sites, you know. The origin is thymus. They produce cytokines and cytotoxins, further promote inflammation and tissue destruction, to release prostaglandins and also cytokines. And the result of that, final result, there is a huge amount of cytokines which initiate and continue inflammatory process, stimulate osteoclast formation and erosions of the joints, and suppress osteoblasts and bone formation. The main clinical presentation is that the most important sign of this disease is that it is chronic. It starts insidiously and chronically, and with a progression course. Once rheumatoid starts, there is no turning back. So the disease progresses, and if it is not cured adequately or treated adequately, it is very important to make destructions and to make patients with low quality of life. The rheumatoid arthritis developed over several weeks to months. There is a constitutional symptoms, fever, fatigue, weakness. The fever is not very high, it is subfebrile, loss of appetite. There is a locally inflamed joints with tenderness, warmth, and swelling over affected joints, muscle aches and stiffness, joint deformity. It is late in the disease, and very important, symmetrical and joint pain and stiffness and swelling lasts more than 6 weeks. It is very important. It is not short living symptom, not short for a short time. It is more than 6 weeks, even though more than 3 months. The morning stiffness is over 30 minutes or an hour, maybe sometimes. Decreased motion and grip strength. Stenosing flexor tenosynovitis, it is called trigger fingers. Extra articular involvement and laboratory abnormalities. very often in this disease, because it is a systemic disease, there is rheumatoid nodules, vasculitis, pulmonary complication, ocular involvement, keratoconjunctivitis, Sjogren's syndrome, cardiac involvement. There is a form of arthritis which is called Felty syndrome, and characteristic for this syndrome is splenomegaly, neutropenia, thrombocytopenia, and lymphadenopathy, and rare complications, kidney injury, and how many complications and extra-articular involvement comprises this disease, because it is systemic autoimmune disease. Laboratory findings comprise elevated SED rate, C-reactive CRP, and positive rheumatoid factors, although there are many types of this arthritis which are negative for rheumatoid factor, negative for anti-CCP. Synovial fluid, it is a turbid with many leukocytes inside, and radiographic erosions in radiographic images. This is the 2010 Acr Classification Criteria. Acr, this is American College of Rheumatology, according to which we assess these diseases according to some types of criteria. You see here, the first criterion is joint involvement, and according to the numbers of joints involved, you have different points, different score. You see, if there is between 4 and 10 small joints involved, you have 3 points. If you have over 10 joints involved, this is polyarticular form, there is 5 points. The second criteria is serology. Negative rheumatoid factor and negative anti-CCP antibodies is assessed by 0 points. If you have high positive rheumatoid factors or high positive anti-CCP antibodies, you have 3 points. Acute phase reactants, normal SED rate and normal CRP is 0, and abnormal ECR and CRP is 1 point, and the duration of the symptoms, if it is more than 6 weeks, you have 1 point. So if you have more than 6 and 6 points of this O criterion, you can say that the patient has a definite illness. What is the difference? Very often you have to practice to differentiate rheumatoid arthritis and osteoarthritis. They're quite different diseases and quite different diseases. You see here the signs of arthritis compare at the right side with osteoarthritis. The morning stiffness is one is the important sign of rheumatoid arthritis. It lasts 1.5 and 1 hour, and worse with activity. Morning stiffness in osteoarthritis is below 30 minutes and resolves with activity. Sorry. Incidence, the females are more often affected in rheumatoid arthritis. Here, the equal gender prevalence. We have equal gender prevalence. Age is very important. The age here in rheumatoid arthritis is in young people between 30 and 50 years of age, and here the age is over 50. Elevated SED rate, here normal SED rate. There are systemic symptoms. There are only local symptoms. Obesity is very important, but not so important as in osteoarthritis. The affected zones of joints are wrists, hands, and feet. Here can be affected also hands, but knees, hips, and spine are more often affected. The distribution is asymmetrical. What are the predictors of worse outcome? This is older age, female gender, genotype HLA DRB1. This is very important for rheumatoid arthritis. Worse physical functioning, and cigarette smoking. Prognostic factors: functional limitation, extra-articular diseases, rheumatoid factor or anti-CCP antibody positivity, bone erosions. You must remember from this lecture that bone erosions are very rheumatoid arthritis is destructive arthritis. It is very important. So because in rheumatology, there are many arthritides which are not destructive. But rheumatoid arthritis is a destructive with bone erosions on radiographic imaging. And it is very important for prognostic factors to manage comorbidities. Comorbidities include infection, osteoporosis, and cardiovascular diseases. These three main groups of comorbidities are very important for prognostic factors and must be addressed in order to decrease morbidity or mortality. The goals of treatment in these diseases is to control disease activity and joint pain, maintain function in daily activities of the patient, and to slow down the destructive joint damage and achieve and maintain disease remission. Because if you enhance and if you ameliorate the symptoms and stop the disease, you can improve or maintain functional status and quality of life of patients. What about the treatment? Treatment overview includes non-pharmacological therapy and pharmacological therapy, which includes non-disease modifying drugs, non-disease, so drugs which cannot modify the course of disease. These are non-steroidal anti-inflammatory drugs and corticosteroids. And the most important group, modifying anti-rheumatic drugs, DMARDs, which can be divided in non-biological, so as synthetic, or biological monoclonal antibodies. From the group of non-pharmacological treatment, very important is rest. When the patient has inflamed joints, he must physical and occupational therapy also is very important. Assistive devices, he must use or she must use assistive devices, very important, and at the end, surgery. What about pharmacological therapy? We shall start with non-disease modifying drugs. They include non-steroidal anti-inflammatory drugs. They have rapid symptomatic relief, but they have many side effects concerning GI tract, especially ulcers and bleeding, renal impairment, hypertension, fluid retention. They are helpful during the first few weeks until definite diagnosis is made. And very important, these drugs cannot affect the course of disease alone. You have to add to adjunct to DMARD therapy. Corticosteroids has very strong and very powerful anti-inflammatory function. They suppress inflammatory response. They can be used as a bridge to effective DMARD therapy because all of DMARDs start late. They have to accumulate and they start late after initiation. So during this period for about 1 to 3 months, you have to start corticosteroids as a bridge in low dose. For example, 5, 4, 10 to 8 to 10 milligrams per day. They have a rapid symptomatic relief, and the dose of prednisone or prednisolone is equal or below 10 milligrams orally daily. But they have many, as you know, many adverse and side effects: hypertension, hyperlipidemia, hyperglycemia, fat distribution, cataracts, osteoporosis, and so on, myopathy, and many others. The most important group for pharmacological therapy are DMARDs. They retard or halt the progression of rheumatoid arthritis and sustain suppression of inflammation. Initiate before 10 months from symptom onset. So early. You have to start them early in the course of rheumatoid arthritis. They can improve outcomes, reduce mortality, and all patients except those with limited diseases functions as to slow down onset with regard to symptom management. Non-biological DMARDs or synthetic DMARDs includes methotrexate, leflunomide, hydroxychloroquine, sulfasalazine, and minocycline. Minocycline is very rarely used. It is antibiotic, but important. The gold standard is methotrexate and leflunomide. In early stages of rheumatoid arthritis, you can use hydroxychloroquine and sulfasalazine. Methotrexate is a folate antimetabolite which inhibits purine synthesis, may inhibit cytokine production and stimulate adenosine release. Initial therapy of choice, it is gold standard, as I said, most likely to induce long-term response. The dose is between 7.5 and 15 milligrams, usually 15 milligrams, even though some rheumatologists use more than 50, about 20 milligrams, once weekly, not every day, once weekly. The onset of action is between second and third week. Methotrexate has many adverse effects: diarrhea, stomatitis, thrombocytopenia, leukopenia, elevating of liver function tests, and because these side effects, you must substitute the folic acid. So to add folic acid, 1 to 3 milligrams orally, toxic effects without compromising efficacy. The contraindications are pregnancy, liver or kidney diseases, alcohol use, blood diseases, and effusions. Leflunomide, or trade name is Arava, inhibits pyrimidine synthesis, and it decreases lymphocyte proliferation. Similar long-term efficacy to methotrexate. The dose is 20 milligrams daily. Early in the treatment, and the old scheme is 100 milligrams daily for 3 days, and then you continue with 20 milligrams daily. But usually today we change the schedule, and usually we start with 20 milligrams from the very beginning every day. The onset of actions about 1. Adverse effects are also similar to as in methotrexate treatment: elevating of liver function tests, pancytopenia, enteropathic recycling prolongs elimination half-life. Cholestyramine can rapidly decrease plasma levels, and contraindications are also pregnancy and pre-existing liver diseases, for example, hepatitis or something like that. Hydroxychloroquine is very useful medication. This drug has low incidence of side effects, and it can be given in pregnancy also, and in nursing mothers. Inhibits polymorphonuclear migration and eosinophil chemotaxis, impairs antigen-antibody reactions. It is least potent but best tolerated. You can remember this because this drug you can prescribe it early in the disease and stages of rheumatoid arthritis. Recommended of patients without poor prognostic factors and low dose duration. The duration of treatment is equal to 24 months. The dosage is 200 to 300 milligrams two times daily for 1 to 2 months, and then you can decrease the daily dose up to 200 milligrams daily or twice daily. The onset of actions at the 6th week. Adverse effects include diarrhea, ocular toxicity, rash, and alopecia, limited monitoring, and contraindications, vision changes from the therapy. So you have to consult your patients very often, not very often, but about 2 times yearly with ophthalmologists to see if there are changes, visual changes from this therapy, and if there is such, you have to stop the treatment. Sulfasalazine is a prodrug, 5-amino salicylic and sulfur acid and sulfapyridine. The mode of action is unknown in rheumatoid arthritis. The efficacy is similar to that of methotrexate. The dose is 1,000 milligrams, 1 gram per orally, daily, initially, then 1000 milligrams 2 times a day. The late onset of action at the eighth week, at the second month, and use limited by is very used very limited by its adverse events, which include diarrhea, anorexia, rash, urticaria, serum sickness, alopecia, stomatitis, liver function tests elevated, and myelosuppression. All contraindications include sulfa allergy. Drug interactions you have to have in mind for drug interactions with antibiotics, iron supplements, and anticoagulants, indirect anticoagulants like warfarin syndrome and others. Minocycline, it is a tetracycline antibiotic which may inhibit metalloproteinases, but it is very rarely used in rheumatoid arthritis. We don't have much experience with that antibiotic in this disease. You can use it in mild disease without poor prognostic factors, and there are limited data about its action and efficacy in rheumatoid arthritis. The dosage is between 100 and 200 milligrams daily. Adverse reactions are minimal. So, in summary, about non-biologic synthetic, you see here this is a table, the dose and the monitoring when you prescribe these synthetic medications. I cannot explain in detail because you see in the table, and I shall upload the lecture. You can download it in your computers or phones to have it and to read all the time when you have free time to read some details. Biological treatment is a modern treatment. It's very important to include and to start this type of treatment when the synthetic drugs are ineffective or there are side effects. They include infliximab, etanercept, golimumab, certolizumab. You see how many biologics are discovered up to date, and some of them are not so efficient, but some of them are with high efficacy. For example, Totalizumab or Rinvoq, Upadacitinib. This is a drug which inhibit kinases, and it is this prescribed orally. Filgotinib, Baricitinib, and so on. This is I repeat this picture to show you the effects of different drugs on different pathogenetic steps in pathophysiology and rheumatoid arthritis. They are genetically engineered protein molecules that target pro-inflammatory cytokines or lymphocytes, not considered as first-line therapy. The patient must have high disease activity with poor prognosis factors, maybe when non-biological or synthetic DMARDs have failed, and are very expensive. TNF-alpha inhibitors are the first group of drugs which are discovered for treatment of rheumatoid arthritis. They prevent and inhibiting immune cell activation, increased infection risk with side effects about tuberculosis, and avoid live vaccines when you prescribe such medication. They can cause multiple sclerosis-like illness. There is increased risk for lymphoma and other cancers. Contraindications are, according to National Association, class 3 and 4 heart failure. And here on this table, you can see different TNF blockers with the dosage, adverse reactions, and comments on the right side. B-cell depleting agent is rituximab, depletes peripheral B cells by binding CD20, cluster of differentiation 20. Recovery takes several months, about 5 to 6 months of these B cells to be recovered. So this is very important because if you make different type of immunization, for example, for COVID-19, you have to stop this medication for 6 months and then to perform the immunization with different types of vaccines, because the main pathological function of this drug is to deplete peripheral B cells. And if you apply when you make at the same time immunization of the patient, you cannot expect immunogenicity of the vaccine, and it will be lost. It is applied for patients who have failed methotrexate therapy or TNF blockers, so it is a second-line drug. Also preferred in recently treated solid malignancy of treated lymphoma or skin melanoma. It is better. There are better outcomes when given together with methotrexate. The dose is 1,000 milligrams intravenously at week 0, and then second week after 2 weeks, and then you have to apply scheme after 6 months. So it is applied. It is given twice yearly. Adverse reactions includes infused reactions, acute infused reactions, allergy. You have to premedicate the patient with corticosteroid and paracetamol, and you can expect the HBV reactivation, so you have to screen the patient priorly to initiation treatment. Warning for fatal infusion reactions. Abatacept is a co-stimulator modulator between CD80 and CD86. Usually, this drug is not used in some countries. In our country, we don't use it. It binds to antigen-presenting cells, preventing interaction between T cells and subsequent. It is applied for patients who have failed methotrexate therapy or TNF blockers, and the response rate is 50% in clinical trials. So you see that there is no very high response rate of efficacy. This is a scheme of the infusion. It's applied at 0, 2nd, and 4th weeks, and then every 4 weeks, every once monthly. The dosage in patients with weight below 60 kilograms is 500 milligrams between 60 and 175 hundredths, and over 100 kilograms is 1,000 milligrams. Or there is an alternative scheme, 125 milligrams weekly. The adverse reactions includes headache, nausea, nasopharyngitis, infections. Interleukin-6 inhibitor, very, very good drug and very often used in rheumatoid arthritis. It is called Totalizumab. This drug can be used in cytokine storm in COVID-19 patients with severe disease, you know that. It is used for patients who have failed methotrexate therapy and TNF blockers, but it can be used, very important, without methotrexate. So patients which cannot, who have adverse reactions from methotrexate or do not tolerate it, you can use Totalizumab alone. The dose is 8 milligram per kilo every 4 weeks. It is intravenously scheme of applications, or subcutaneously 162 milligrams every other week, or in 160 milligrams weekly. Adverse reactions include infusion reactions, hyperlipidemia, liver function, elevated liver function test, and infection. You have to monitor baseline and periodically blood counts, blood count. Interleukin-1 inhibitor, anakinra, don't use in. I mentioned here because to your knowledge, information about this interleukin blocker, but we don't use in rheumatoid arthritis. It is often used in gouty crisis and in some other inflammatory diseases. This is the dose here. I cannot stay on this slide long. And JAK inhibitors, they are new drugs relatively new drugs which we use for rheumatoid arthritis, Tofacitinib. It is approved by FDA in 2012. It is applied in moderate to severe rheumatoid arthritis refractory to methotrexate. The dose is 5 milligrams 2 times a day. Adverse reactions: diarrhea, headache, infections, malignancy, and you must test the patient for tuberculosis primarily before starting, and for hepatitis B and C prior to therapy initiation. You have to monitor hepatitis panel, so liver function test, TB spot, TB test, and cell blood count, leukocytes, and hemoglobin, and lipids, of course. Other agents include gold cells, azathioprine, depenicillamine, which we use rarely, cyclosporin, and cyclophosphamide. They are infrequently used and or not recommended because of toxicity, lack of long-term benefit, or both. Combination, usually in severe forms of rheumatoid arthritis, we use typically combination therapy, which is effective when monotherapy fails to improve quality of life of patient. May be appropriated initially in moderate to high disease activity. Biologics, usually we use biologics in combination with methotrexate, may be more effective. Monotherapy and combination therapy with more than one biologic is not recommended. It is very important because the efficacy is not higher, but the side effects are higher. And this is a scheme when you choose in different prognostic factors, in different prognosis of rheumatoid arthritis, to choose what scheme of treatment to use. Very often and it is necessary to evaluate the therapy, to monitor the patient every 3 months, or in case of severe disease every month, for this clinical signs and different criteria for improvement of rheumatoid arthritis. This is all for this lecture. Now I suggest to have 5 minutes break, if you don't mind, and to continue with another one. I think we'll be in time because now it is 15 past 5, so we have time till 6 o'clock to perform another presentation. Do you agree? I think that 5 minutes rest. You can rest 5 minutes. I shall upload another lecture now, and we shall wait for 5 minutes to have a break for a little bit of coffee or something like that, and we shall start in 5 minutes.
Okay, Professor.
All right. I can upload the lectures in the platform of Big Blue Button, and you can download them after finishing in order to have them for your preparation for the exam. Do you?
Okay, Professor, thank you.
Because sometimes you can listen but you cannot remember everything because it is impossible. And sometimes, if you have lectures, you can see every slide and to remind what I know, the different pictures, the different schemes. I think that you can use this lecture for your preparation for the examination of internal diseases. It is very important because rheumatology is a difficult specialty, and you have to have knowledge in internal diseases in order to graduate in rheumatology. It's very, very, very important.
Mhm. Yeah, it's gonna help. Thank you.
If you have, at the end of this presentation, the second one, seronegative spondyloarthropathies, if you have any questions or comments, you can forward them to me to discuss or to clarify some unclear unclear questions or unclear points of view for these presentations.
Okay.
So is spondyloarthropathies. Why they are called seronegative? Because you shall see now. You see here one human man. This is at the beginning of disease, and this is at the end of disease. So deformity of the spine. And here at the right hand side, you see the X-ray with the bamboo spine. So this is the evolution of diseases from here to here. This is the end stage. This is the initial stage. So these spondyloarthropathies are group of diseases which are characterized by common signs. The first is inflammatory skeleton involvement, sacroiliitis or spondylitis, asymmetrical peripheral arthritis as a difference with rheumatoid arthritis, enthesopathy, this is very important, and inflammatory eye diseases in overlapping mucocutaneous features, and very important, presence of HLA-B27 antigen. And most important, absence of serum rheumatoid factor. These patients with spondyloarthropathies are negative for rheumatoid factor. You see here a picture with these spondyloarthritis. This is a spectrum because they have overlapping signs, and sometimes they cannot be differentiated each other. And you see there overlap, ankylosing spondylitis overlap with psoriatic arthritis, sometimes with undifferentiated and so on. This is a spectrum of these diseases. What is the role of HLA-B27? B27 has protein antigens that have been synthesized in the cell, for example, viral, tumor, or self-derived to cytotoxic T cells. So this is a protein. B27 is a protein which is expressed on the surface of some, for example, cytotoxic cells, which can uh, uh, the patients with which are B27 positive individuals are less efficient at elimination intracellular organisms, for example, chlamydia and certain enteric bacteria. It's unclear if disease susceptibility is due to presentation of artertogenic peptide, failure to intracellular organism versus itself source antigen. There are 20 different subtypes. For example, B27.4, B27, which accounted for most property. And pathogenesis is 7 positive. It's a macrophage, and this is a molecule B27, which presents the antigen, this pink point, to T cell receptors. Interacting with macrophage, which is expressed B27 with T cell, generate intense inflammatory. 94% antibodies are B27 positive, and bacterial infection trigger the molecules are believed to have evolved in response to environmental stressors for bacterial infections, but B27 can be found as a gene can be found in 8% of Caucasians, 3 to 4% in African Americans. Risk HLA B27 positive person, only 10%. So not only be present to start disease. So there are many environmental factors and stressors which, in combination with this, can cause. There is 20 to 30% risk the first degree AS. So patients who have relatives positive for B27, 20 to 30, about 30% risk to develop ankylosing spondylitis. But no justification to test asymptomatic relatives. B7 increases spondylitis and uveitis. So when patients bear this antigen, the risk for spondylitis and uveitis. And you see here the frequency of B27 and spondyloarthropathies. For example, ankylosing 95%, the most abundant. Undifferentiated spondyloarthropathy, 70%. Reactive arthritis, up to 80%. Colitis associated with spondyloarthropathy, for example, these are so-called spondyloarthropathies in IBM, inflammatory bowel, is up to 75%. Psoriatic spondylitis, up to 50%. Psoriatic peripheral arthritis, up to 25%. Iritis, up to 50%. And cardiac conduction defects in 80%. This is the pathology of spondyloarthritis. Usually, there is a subchondral tissue which become, and if you inflammatory cells, there is a bone reactive cirrhosis and resorptions, which is called erosions. There is bone remodeling. Cartilage replaces of normal tissue. And after that all, there is a new bone formation and ankylosis. The very important sign in this group of diseases is enthesitis and so-called dactylitis. Both of them, they cause gradually inflammation of the joints of the spine, and there is new and ankylosis. You see here, this is a patient with synovitis of the knee, which could be a sign of rheumatoid arthritis, but usually as I said in previous lecture, polyarticular disease, and usually it is symmetrical disease. Here there is asymmetric joints, which should not be considered in the different pneumococcal arthritis. It is infection arthritis called internal derangement of the knee, systemic lupus erythematosus, gout, seronegative spondyloarthropathies. Of all these, only systemic lupus and osteoarthritis and rheumatoid arthritis could be excluded from the differential diagnosis. In this picture you saw before this. So these patients cannot be classified as having lupus or rheumatoid arthritis or what else, or systemic lupus or osteo. How can we make the diagnosis? First, you have assess the enthesitis. This is a characteristic feature of AS and spondyloarthritis. Inflammation at what is enthesitis? It is inflammation at tendons, ligaments, or joint capsules attaches to bone. Primarily affects the sacroiliac joints and axial skeleton in ankylosing spondylitis, but extra-articular or extra-articular bony tenderness occur from the enthesitis at the many other sites. You see a picture here. This is an enthesitis of Achilles tendon. You see this swelling, big swelling, and inflammation is very painful, and the patient cannot. The reasons could be inflammatory, usually spondyloarthropathies, but the reasons could be mechanical or degenerative, and also metabolic or endocrine. What are the extra-articular manifestations? Because spondyloarthropathies are also systemic and inflammatory diseases. Usually, associated extra-articular features are ocular, up to 40%, uveitis, conjunctivitis, heart, 30%, aortic insufficiency, heart block, aortitis, lung, up to 10%, interstitial lung disease, apical fibrosis, and aspergilloma. Kidney, up to 15%, which can be verified as amyloidosis, nephritis, or IgA nephropathy. Bones, osteoporosis, bone resorptions, and bone formation. Gastrointestinal, oral ulceration, asymptomatic inflammation, symptomatic colitis. Genitourinary, urethritis, vaginitis, balanitis. Cutaneous, keratoderma, blenorrhagicum, usually in this disease, syndrome, and psoriasis or nail lesion, dystrophy, and pitting. Now we shall go to psoriatic arthritis, another spondyloarthropathy diseases. Psoriatic arthritis is chronic inflammatory arthropathy of psoriasis. So you have to have, the patient must have psoriasis, skin disease, and then to develop inflammatory arthritis. The site of psoriasis are scalp, ears, gluteal fold, umbilicus, perineum, nails, extremities. Nail changes are very in these patients. There is pitting, dystrophy, or honeycomb. And for example, in US populations, 1 to 5% has psoriasis, and 5 to 42% of these patients with frequency, the severity and duration. The course is chronic, and there is between 50%. You see pictures of different type of psoriasis. The classification of psoriasis and psoriasis especially can be divided in several: asymmetric polyarthritis or oligoarthritis, symmetric polyarthritis, sometimes differentiable with rheumatoid arthritis, difficult to differentiate because there is a symmetric form, spondylitis, distal interphalangeal joint disease, and arthritis mutalis. And you see here the percentage of involvement, and you see here that in the middle column, key clinical features. And now you see here patient with different types of affected joint, and here in the center is the X-ray of spondylitis, very rough syndesmophytes. They are not smooth syndesmophytes. Difference in ankylosing spondylitis. This is a pencil in cup and cup deformity. This you see here, this joint, this joint, this joint. The next spondyloarthropathy is inflammatory bowel disease associated arthritis or in ulcerative colitis. Clinical features of ulcerative colitis, you see here, you know it because you have past gastroenterology, and this is the clinical features of Crohn's disease. Both these diseases, and sometimes the up to 40% of inflammatory bowel patients develop arthritis. Risk in further manifestations, for example, abscesses, erythema nodosum, uveitis, pyoderma gangrenosum, and so on. And gut disease may be asymptomatic for years. There are different subsets of this IBD-associated arthritis. The first one is asymmetrical oligoarthritis. It could be intermittent or chronic. Seronegative rheumatoid arthritis like polyarthritis, so it's similar to rheumatoid arthritis in 20% of IBD patients, and spondylitis up to 15%, which may be diagnosed as ankylosing spondylitis. Very important, the peripheral arthritis parallels the gut, not the spine. So when you have symptoms from the gut or very active, it is most important that peripheral arthritis is active, but there is a correlation between symptoms. Sacroiliitis is related to the duration of disease. These are here a picture and scheme for extraintestinal manifestations of IBD. See them? For example, pyoderma gangrenosum, they are very, very severe complications and very difficult to treatment sometimes. Uveitis, clubbing fingers. Which are the tests for spondyloarthritis? Which tests investigate B27. Patients sometimes may have normal ECR or CRP despite active disease. Alkaline phosphatase may be elevated. There is normochromic, normocytic anemia. Imaging is an important method for assessing the especially inexpensive, ready available very often, and poor sensitivity, but it has poor sensitivity, and the changes in X-ray and the X-ray of arthritis type of diseases are seen in 1 to 9 years after the symptoms, usually 4 to 5 years. So the patients must have 5 years to see changes in the X-ray. CT scan, the radiation exposure, but good to detect sclerosis, erosions, and ankylosis. An MRI, it is expensive, but most sensitive to detect the early changes, bone marrow edema, and effusions. SPECT scan may be help in equivocal cases, and the sensitivity and specificity is questionable. This is an algorithm of the imaging investigations to assess the presence of spondyloarthritis. You see here, if you have radiograph of spine, low back spine, or pelvis, or sacroiliac joints, you go to, if you have grade 1 of sacroiliitis on X-ray, you can start with, if it is a normal X-ray of these joints, you make MRI. And if you have grade 2 or 4, between 2 and 4 sacroiliitis, you don't need to make neither CT or MRI. You see here the X-ray of sacroiliitis, narrowing the space joints, erosions, and magnified to see better. You see here, this is not normal. You see here, this is this is bilateral changes of the third stage of sacroiliitis. You see a CT scan of sacroiliitis early. This is early stage and the late stage. You see here the X-ray of the spine, lumbar spine. There is you see here a spine, very smooth and syndesmophyte. Difference in psoriatic spondylitis, where they were very rough and syndesmophytes. This is a so-called dish diffuse idiopathic skeletal perostosis. Dish diseases or dish syndrome is a osteoarthritis of the spine. You have never could be seen as sacroiliitis. Of sacroiliitis exclude ankylosing spondylitis and confirm the diagnosis dish. The picture is absolutely the same with ankylosing spondylitis. What is the assessment and the monitoring of the diseases? You need to assess baseline disease therapeutic responses. Tools which we use in their indexes to measure aspects of disease are BASMI, BASDA, and BASFI. This is Bath Ankylosing Spine Disease Activity Index. It is not used for you because this is important for rheumatologists who can assess the activity and the severity of disease. This is the World Health Organization or International Against Rheumatism for assessment of ankylosing spondylitis. Useful scheme, but also for rheumatologists, for specialists. And what are the most important in the management of these diseases? The objectives include to relieve the pain, to relieve the stiffness and fatigue, and maintain physical and psychological and psycho function. What are the ankylosing spondylitis and spondyloarthropathies? You have to do appropriate patient selections before beginning treatment arthritis, and to ask yourself is the disease active first, and what aspect of ankylosing spondylitis we are treating. If we have enthesitis, this medication is peripheral arthritis medications, and if you have spinal disease, you have what are the therapeutic options? They are not quite different in comparison with rheumatoid arthritis. Non-pharmacological measures, you remember from the previous lecture, and pharmacological therapy, usually non-steroidal, are the mainstay of therapy. Corticosteroids are rarely used in these diseases, and they are rarely effective. DMARDs include sulfasalazine and methotrexate, but only for peripheral disease. They don't have efficacy in axial disease, in spondylitis. And the most important are biological with TNF blockers. Nsaids, as I said in the previous lecture, they are very effective, but they suppress the inflammatory process, the back pain, spinal stiffness, and peripheral arthritis, and also enthesopathy, but they have very many side effects, especially on GI tract and cardiovascular systems. COX-2 inhibitors, know about them. They are more with less side effects and more effective. In patients who are Nsaids resistant, you have to consider synthetic DMARDs, and which DMARD you have to choose, methotrexate or sulfasalazine. As I said, they're indicated in psoriasis and for peripheral arthritis and in spondylitis with peripheral involvement, but they have much hepatotoxicity. The gold hydroxychloroquine, azathioprine, and leflunomide, they have no effect, ineffective DMARDs in spondyloarthropathies. Sulfasalazine is very often used in reactive arthritis, and it shows very good results in peripheral arthritis, in Reiter's disease, and which is the rationale for TNF therapy in spondyloarthropathies. If you have enthesitis, if you have very active diseases and very severe course, you have to use blockers. This is histology, and this histology of the sacroiliac joint. These black dots here, this is a TNF cytokine which this joint, which shows very active inflammation. The first and very effective TNF blocker used in ankylosing spondylitis is etanercept or Enbrel. Very often we use it in these diseases. Infliximab also. Efficacy, you see here the comparative MRI, compared pictures before treatment. This is with the arrow show that there is a bone edema in sacroiliac joint. After the treatment with infliximab, the status of this sacroiliac joint. You see these here light spots with the arrow show inflammatory of the sacroiliac joint. This is ASAS 20. This is ankylosing spondylitis activity score in 20% of symptoms response with adalimumab. It's a study which you must not remember, but the risk, the relative contraindications of anti-TNF treatment are many, and they include positive PPD, tuberculosis test, history of untreated tuberculosis, current active infection, chronic recurrent infections, history of decompensated chronic heart failure and lymphoma, systemic lupus, and demyelinating conditions, for example, MS or optic neuritis. Very often in this ankylosing spondylitis is seen osteoporosis, which can cause, as you know, it is a silent epidemic and can cause fractures of the bones, and they can be disabling the patients and with very low functional and quality of life and very low functional status. In summary, we can say that these diseases, spondyloarthropathies, are more common than previously thought, and they're often diagnosed late, causing significant functional disability. Very often you have to consider the differential, recognize the role of labs and imaging. Therapies provide symptomatic control. DMARDs have no role in spinal diseases, synthetic DMARDs, I mean. Osteoporosis is very common in ankylosing spondylitis, but biological therapy, and especially TNF blockers, improve symptoms and productivity, potential to modifiable outcomes in ankylosing spondylitis. In conclusion, we could say that spondyloarthritis are inflammatory arthropathies. They share genetic, clinical, and radiological features, antigen driver immune response causing symptoms, and new in the face of biological treatment allow for more effective management and improving quality of life of these patients. So this was, colleagues, for the second presentation. If you have any questions, I think we are in time. It is 10 to 6. If you have any questions, you can forward them to me. You can speak instead of writing. If it is everything clear, when I upload the lectures and you go over them again to see them, to repeat them, next time you can go back to these lectures with your questions, but very briefly to explain to you some unclear things and some things you would like to know. Next time we shall speak about systemic connective tissue diseases. This is a huge problem in rheumatology, and the diseases which comprise lupus, scleroderma, myositis, inflammatory myopathies, they're very difficult to treat, very life-threatening sometimes, and they're very important in your practice because they can they can be very difficult to differentiate with with infections, with some other diseases, with cancers, with neurological diseases. They're very interesting, and you have to know the basic things about these diseases. But we will talk about them. We'll speak about them on a presentation next time. The next time will be 20th of January, at the same times 4:30. We shall start with the next presentation. So I can say you have a good evening and all the best till next week.
Thank you very much, Professor.
Thank you. See you next time on
See you.
20th of January.